Welcome, everyone. Thank you all so much for joining us today. My name is Sarah Gudema, and I'm a project coordinator and specialist at the Association of Clinicians for the Underserved. Typically, Diane Thabby King, Senior Public Health Advisor in the Division of National Health Service Corps from HRSA, would provide our introduction, but she was unable to participate today. She wishes she could be here with you all. I'm just taking her place instead and want to welcome you to Leading During a Public Health Crisis, Part 2, Protecting Clinician Mental Health. Today's presentation is part of the second webinar series that we have provided as part of the National Health Service Corps Empowering Clinicians for Resiliency and Transformative Care initiative. To our NHSC participants, we are so thankful for your dedication to serving historically marginalized and under-resourced communities. This is such important work, and you are part of the solution to achieving health equity. To our NHSC approved site staff, thank you for supporting your clinicians and coming here to learn more about how to create a work environment that fosters clinic well-being for all. We truly could not do this work without you. Our first webinar series was geared towards NHSC participants and how they could identify and address burnout in themselves and their colleagues. We even included ways they could advocate for organizational changes in NHSC-approved sites to reduce the experience of burnout. All of the materials from those webinars and related resources are available on our archived resources page. We'll post a link to that in the chat now. This second webinar series, Fostering Resilience at the Organizational Level, is really geared towards leadership staff at NHSC approved sites who have the ability to make positive changes at the organizational level. We recently completed our mini-series on organizational resilience, where we followed the framework offered by the National Academy of Medicine on the 6 domains of organizational evidence-based and promising practices for improving clinician well-being. And last week was the launch of our current mini-series on leading during a public health crisis, where we discussed key skills needed for leadership staff to successfully navigate public health emergencies and support clinician well-being. If you would like to review the materials from that webinar, you can find them on the webinar registration page with the link in the chat. Today's webinar is the second in our mini-series on leading during a public health crisis. Public health crises introduce new stressors into the daily lives of clinicians, personally and professionally. We saw this play out during the COVID-19 pandemic when many clinicians struggled to balance caring for their patients, managing their own fears of the virus, and protecting their families. Clinicians can also experience moral injury during crises as they are forced to make difficult medical and personal decisions due to limited resources and time. Fortunately, healthcare leaders like those of you on this call have the opportunity to implement structures and practices to help mitigate those stressors and bolster clinician mental health during crises. We are truly grateful that you have decided to join us today to learn more. During today's webinar, Dr. Taylor-Desir will discuss tactics to support healthcare team members over the course of a crisis and practical interventions that can be implemented on the individual, organizational, and societal level. The final webinar in this mini-series on June 21st will focus on measuring burnout among your clinicians. We hope you can join us for that webinar as well. We're extremely excited to have Dr. Monica Taylor-Desir for today's session to share her experience and expertise with you all. Dr. Monica Taylor-Desir is a senior associate consultant with the Department of Psychiatry and Psychology at the Mayo Clinic, where she serves as a community psychiatrist for the Olmsted Assertive Community Treatment Team and as the co-chair for the Mayo Midwest Department of Psychiatry and Psychology Equity, Diversity, and Inclusion Committee. She is a current member of the Health Equity and Racial Justice Committee of the Minnesota Psychiatric Society. She also serves on the National Network of Depression Centers Racial Diversity and Equity Workgroup. Prior to joining Mayo Clinic, she worked as a community psychiatrist for tribal communities in Arizona for 12 years and as the chief medical officer and psychiatrist for a community in North Dakota for 3 years. She graduated from the University of Cincinnati College of Medicine and completed her psychiatry residency and a fellowship in community psychiatry at Emory University. She has served as the Arizona Psychiatric Society newsletter editor, treasurer, and secretary, and as the North Dakota Psychiatric Society president-elect, and at the national level as the North Dakota APA Assembly representative. She also has the pleasure of serving as the American Psychiatric Association Foundation Board Secretary. Before I hand the mic to Dr. Taylor-Desir to get us started, I'd like to go over a few housekeeping items. This webinar is being recorded and a link to the recording will be emailed to you all within 2 days. The PowerPoint slides can be found on the webinar registration page, which we'll link in the chat now. Related documents and previously recorded webinars in the mini-series are all available on the webinar registration page. This is a 1-hour webinar. We'll have time for Q&A at the end of the presentation, so please type questions you have for the presenter in the chat box on the right side of your screen. You may have to manually open the chat box by clicking on the 3 dots in the bottom, or on the chat icon in the bottom right-hand corner. There will be opportunities to engage with Dr. Taylor-Desir and other participants during the presentation through polling, chat box, and raising your hand to speak. You should see a poll pop up now on the right side of your screen to help us get a sense of who's in the room. Please go ahead and complete that as I finished the housekeeping items. If you have any technical assistance questions, please contact our colleague Josh. His contact info is pasted in the chat. Finally, we would greatly appreciate your feedback on today's session. Please complete our survey at the end of the webinar to let us know how we did and how we can improve our trainings. To see closed captions, click on the CC icon on the bottom left-hand corner of the webinar window. I will hand the mic over to Dr. Taylor-Desir to begin our presentation.
Thank you so much, Sarah. I really am excited to join you this afternoon. I'd like to add 2 other items. I am a former National Health Service Corps scholar, and I served 4 years at the Winslow Indian Healthcare Center in Winslow, Arizona. And as previously mentioned, then continued to work in tribal communities for an additional 12 years. And then I am also a former National Advisory Council member to the National Health Service Corps. So I served from 2019 to February of this year. So again, just very happy to be here with you this afternoon. So let's start our webinar this afternoon on leading during a public health crisis, protecting clinician mental health. And let's see if I can get it to the next slide. Here we go. Our learning objectives this afternoon are that you will learn various stages of a public health crisis and their impact on mental health. You would gain an understanding of strategies at the individual, organizational, and societal levels for protecting the mental health of clinicians, and that you will learn different ways that health systems have implemented resiliency programs. We'll also give you an opportunity to practice implementing strategies for discussing burnout and resiliency with staff. Numerous factors contribute to elevated stress. Hold on just a minute. There we go. Numerous factors contribute to elevated stress among healthcare workers, including heavy workloads, long shifts, a high pace, and lack of physical or psychological safety. It can also include chronicity of care, moral conflicts, perceived job security, and workplace-related bullying or lack of social support. In addition, COVID-19 related stressors included lack of childcare, caring for sick family members, being isolated from family members, having mandated overtime, and a higher likelihood of contracting COVID-19 due to exposure, also experiencing emotional distress from patient deaths and grieving families. The resulting psychological distress from typical stressors and or COVID-19 related stressors can lead to burnout, depression, anxiety disorders, sleeping disorders, and other illnesses. Work-related stresses can have a negative impact on healthcare provider professionalism, quality of care delivery, efficiency, and overall quality of life. Therefore, it is critical to identify and mitigate these work-related risk factors to protect the mental health and well-being of our healthcare workers. Working in a stressful or challenging environment for long periods with little recovery time is a risk factor for burnout. And burnout is defined as an occupational phenomenon in ICD-11. It states that burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed, and it is characterized by 3 dimensions. Number 1, feelings of energy depletion or exhaustion, increased mental distance from one's job, such as feelings of negativism or cynicism related to your job, and number 3, reduced professional efficacy. Burnout refers specifically to phenomena in the occupational context and should not be applied to describe experiences in other areas of life. Maslow and others describe burnout as that point at which important, meaningful, and challenging work become unpleasant, unfulfilling, and meaningless. So energy turns into exhaustion, involvement, also noted as work engagement, becomes cynicism, and efficacy is replaced by ineffectiveness. Here you see a quick overview of the role of moral distress and moral injury in burnout. This is a conceptual framework looking at work conditions that lead to moral distress and work conditions that lead to moral injury and burnout. There has been an increasing focus on moral injury and the relationship to burnout, especially during the COVID pandemic. Moral distress is the inability to provide needed services to patients because of reasons outside of the clinician control. And moral injury has been defined as when we perpetuate, bear witness to, or fail to prevent an act that transgresses our deeply held moral beliefs. It can also involve an experience of betrayal from leaders or trusted others. It often involves a double bind where a person finds it impossible to do what is ethically required. Moral injury is not considered a mental health condition, but it can be associated with depression, post-traumatic stress disorder, and anxiety. There is a resource that we have placed in the chat from the American Psychiatric Association that did a COVID-19 guidance document called Moral Injury During the COVID-19 Pandemic. And this was prepared by the American Psychiatric Association Committee on the Psychiatric Dimensions of Disaster and COVID-19. And again, that link is being placed in the chat. So when we look at the role of moral distress and injury and burnout, we can see that there are moral dilemmas, and this can be mitigated by reflection rounds or ethics consultation, which we will talk more about towards the end of today's webinar. If you're experiencing moral distress, mitigation can happen through system changes, improved staffing, decreased workload, and discussions of equity and providing more support. And this is also happens to be mitigating factors for moral injury. And also looking at mental health protection programs, which again, we'll talk about more towards the end of the webinar to prevent burnout. So we're going to talk about several phases of a public health crisis. And the British Psychological Society developed a guide for healthcare leaders, which included 4 phases: preparation, active, phase, which is parts 1 and 2, and then recovery. This particular healthcare guide provides details on identifying characteristics and hazards to watch for across each phase. It also identifies tactics to support leadership and the healthcare team across each phase. In addition, I'm also providing another resource for you in the chat, which is if you'd like to delve further into this topic, it's a 9-course interactive module through the American Psychiatric Association. Dr. Joshua Morgenstein, who's the captain of the U.S. Public Health Service, was kind enough to present to the National Advisory Council for National Health Service Corps, and he's over disaster and preventative psychiatry. And this module also provides more in-depth resources on the phases of a public health crisis, but also talks about psychological first aid and roles for the emergency responder and tools for leadership. As we go through this webinar this afternoon, I'd like you to also think about not just public health crises in terms of viruses, but also think about wildfires, hurricanes, flooding, tornadoes, and things that happen that are man-made, such as mass shootings. In the first phase, the preparation phase, most people will experience preemptive anxiety. What's going to happen? There's a lot of uncertainty. Then we'll go into the active part 1, active part 2, and recovery phases. The identifying characteristics in the preparation phase are not feeling prepared, feeling uncertain, and feeling overwhelmed. Hazards often include a lack of sleep, increased worry, and stress. In the preparation phase, tactics that you can use to support yourself and the team are to assure the staff that all emotions are normal. Also, control what you can and accept what you cannot, and encourage and stick to routines during this phase. In the active phase, there are often lots of heroics seen. People are focused on a surge to solution, and this is often a time that is weeks to months after the impact of a public health crisis or a natural disaster. The surge to solutions can focus on survival, on rescue, on promoting safety. Some of the identifying characteristics include increased camaraderie and morale. People will often rise to the challenge. Some people will feel out of control. There may be disagreements over a sense of urgency. Some social norms and niceties lapse, and we see pressure mount. Hazards that are related to this active phase, part 1, include reliance on instinct, which often leads to higher risk of error. Sometimes there is a decreased capacity to assess risk. Frustration and role confusion. There may be a loss of routine regarding work hours and breaks. Often overworking occurs during the active phase, and there's task-oriented focus with often a decrease in communication. Tactics that you can use to support yourself and your team during the active phase, part 1, is encouraging a healthy work-life balance and regular breaks. So be on the lookout for people who are overworking, Help the team to connect with each other and make sure you are setting aside time for rest. It's during this phase that mental health resources are often well received. In part 2 of the active phase, which may be months to years after the impact of the initial public health crisis, persons may experience disillusionment and exhaustion. This is a time when people begin to recognize the limits of available assistance. Often, if there is a surge of voluntary support or a surge of supplies, those have begun to taper off, and volunteer groups may start to pull out. Some people during this time may have the characteristics of feeling like we should move full steam ahead. There can be sudden exhaustion and emotional disconnection, compassion fatigue. Hazards during this period include that this is the phase of highest risk. For weeks and months that this public health crisis has gone on, especially in our healthcare workers, we can neglect our own physical and psychological health. There's ethical distress due to limited healthcare provision. People may become avoidant or use unhelpful coping mechanisms. And this is the time to be aware of suicide risk in staff with pre-existing vulnerabilities. And that being said, by virtue of being in healthcare, we have a higher risk of suicide. Nursing, frontline providers, and persons that are working in rural or farming communities also have high risks. Tactics that you can use to support yourself and the team during part 2 of the active phase is to remind yourself to be compassionate towards yourself and others. Be willing to ask for help. Listen and communicate, and continue to uphold your team's physical safety. Make every effort to share and highlight positive experiences and express appreciation. In the recovery phase, key features include persons that are often recovering from this initial increase in work, but there may be those who have long-term psychological impacts. Identifying characteristics include that staff start to reflect on what has happened over this time period where they have risen to the occasion. Most will cope successfully. People note a positive change and personal growth, but some may feel resentment and experience mental health consequences. Hazards during this time include intrusive shame or guilt, thoughts of what should have been done differently, and there is a conflict with being the hero or society identifying you as a hero and feeling that things weren't done as the way they should have been. People often experience burnout during the recovery phase, and this is important to note. And we also see symptoms of post-traumatic stress disorder. Tactics to support yourself and your team include, again, encouraging sharing of experiences and emotions, listening to staff needs, and identifying steps to address them, connecting staff to resources to access professional treatment, making sure to celebrate successes, involving staff in developing future preparedness plans, looking at what worked and what we can do better, and giving thanks and distributing rewards. Now we will move on into the interventions for clinician well-being. We will start by looking at interventions for individuals, then move to organizational interventions, and then societal interventions. Even though it looks like the process is linear, as was previously noted in Sarah's introduction, really organizations have the responsibility for creating a space that allows and promotes individual well-being and resilience. So we're not saying that the individual is responsible before the organization. We're just going to start with individual interventions this afternoon. So previous pandemics have seen high psychiatric comorbidities among healthcare workers. Protecting clinician mental health in the aftermath of the coronavirus disease 2019 has required an evidence-based approach to developing and deploying comprehensive clinician mental health support. In a narrative review of 96 articles addressing clinician mental health in COVID-19 and prior pandemics, 7 themes emerged. The number one was the need for resilience and stress reduction training. Number 2 was providing for clinicians' basic needs, such as food, drink, adequate rest, quarantine, appropriate housing, transportation, childcare, and personal protective equipment. Also noted was the importance of specialized training for pandemic-induced changes in job roles, recognition and clear communication from leadership, acknowledgement of and strategies for addressing moral injury, and the need for peer and social support interventions. And finally, the normalization and provision of mental health support programs. So looking at the individual level, we looked at providing resilience and stress reduction support. One of them is anticipate, plan, deter trainings, or APD trainings. This model incorporates pre-event training, which is anticipation of a public health crisis or natural disaster, explaining the nature of cumulative responder stressors, and anticipating stress reactions. Then there's the development of a personal resilience plan, also known as your plan step, to identify and document anticipated challenges and positive coping strategies. And this is so important. Hopefully, if there's nothing you take away from today, is to decide that you will develop your own personal resilience plan. When I have done trainings for college students, for medical students, for residents, for community members on suicide prevention, I often use the Stanley Brown safety plan. And everybody looks at me like, why do we need a safety plan? I haven't thought about being suicidal. I'll never be suicidal. I'll never be in that emergency. But you should never say never. And it's always good for you to have a plan when you are thinking clearly. Because when you get into that crisis or into that stressful moment, you can't think clearly and it's hard to focus on what is helpful. So the development of a personal resilience plan should be on your things to do, at least this afternoon or for the next week. And then final step, and anticipate, plan, and deter trainings, or to have trainings of participants on monitoring self-stress and monitoring of your response when you are exposed to stress, so that you know when to implement your personal resilience plan. Second, Fessel and Chernis identified actionable micro practices for physicians to implement during the workday, such as wellness self-checks and naming their emotions. This could be done at any time that there were regular cues during the day, such as hand washing, taking deep breaths during hand washing, or doing hand sanitizing, thinking about deep breath, where's your tension, naming the emotions. And also another thing is every time they logged onto the computer, and so maybe for some of you, like me, it takes a while to log onto my computer. So maybe naming 3 things that you're grateful for as you're logging onto your computer or getting to the next station. So that is a micro practice. Peer support is establish formal peer support models and encourage informal peer support models. And again, encourage professional treatment when needed. So we have our first question for our audience. What interventions have worked well for your staff? And you can put that into Slido or in the chat. I think we're using Slido.
Yes, and for any participants who feel comfortable sharing aloud, you can click the raise hand icon, which is found towards the center lower bar of your screen. And if you click that, we can unmute you and allow you to speak to the group.
And I'll give some time for responses. And it doesn't have to be these 4. You could use anything that you've used in the past. Okay, great. I see peer support, crisis prevention, recognition, yes, encouragement through EAP, and using employee provided mental health services. Great, thank you. There's also a provision of, there's a psychological well-being for health and care workers. It's a digital guide, and you can look this up. That was developed by Blake and colleagues. And some of the topics that were used were creating a psychologically safe space in the workplace, key actions for team leaders and managers, addressing social stigma, communication approaches, accessing support in the workplace, accessing family and community support, supporting and signposting others, such as using the psychological first aid. They also included self-care strategies, the use of rest and work breaks. They also talked about persons who work the night shift, the importance of sleep, and managing your own emotions. Another intervention on the individual level is to monitor and support clinicians that may be experiencing psychological impacts. For example, being honest and transparent about what clinicians can expect to experience and witness during the crisis. So now that we've all come through COVID-19, you're now all experienced and wise and can talk about what clinicians may experience. Rotate workers across high and low stress functions, so the same person isn't doing the same thing all of the time. Provide trainings on potential traumatic events clinicians may be exposed to and how to cope. Implement a meaning feed feedback process, and monitor clinicians who may be especially vulnerable due to pre-existing mental illness such as depression, post-traumatic stress disorder, anxiety, those who've experienced previous traumas, and concurrent pressures and loss. And encourage clinicians to use peer support and other professional services. At the organizational level, we're looking at providing resources for clinicians' basic needs. So one is designing an area for well-being. And this is a strategy to address clinicians' basic needs during the COVID-19 pandemic, which range from covering basic meals and transportation needs to establishing a well-being area within the hospital in which staff and volunteers safely from family. One hospital in China created videos of the daily routine so that family members would know what they were doing and have a better picture in their mind. Providing transportation options for persons in urban settings that rely heavily on public transportation. During the pandemic, for some of my colleagues that worked in Native American rural communities, they were able to provide gas cards because a bus wasn't running. So that was one option for providing for basic needs. Other basic needs included childcare and PPE. What have clinicians raised as basic needs during the pandemic, and how did you address them? And if you don't have an example from your own experience, maybe one of your colleagues or a person that worked in a different facility. And I'll give us some time for people to put in the answers. And if people have thoughts about maybe a well-being area that was created in your facility or place where people could rest, that would be also an answer. Thank you for sharing, Ronald. I think sometimes, you know, we have short memories, and you think about we're emerging from the public health crisis, but at the beginning there was not enough PPE and not even enough for families. So I'm sure that was meaningful, so that there was PPE that people could take home to their family members. Also, at the organizational level, we need to provide training for new job roles. So many people were redeployed to different work areas in their facilities. And delivering care during a pandemic requires operating in a high anxiety environment, and in many cases, being prepared to assume new professional roles to meet evolving needs. So training clinicians on infection control proved to be a way to alleviate stress because it armed them with protective tools. Formalized training on how to identify and respond to patients' psychological distress was requested as another strategy for clinician support. And finally, redeployment to a new clinical role in the case of a patient surge was a core source of anxiety that could be addressed through assessment of clinician skill sets before redeployment, targeted training, and improved information about redeployment plans. So the first question is, how did clinician job roles in your facilities change during the pandemic? Oh, and I see the second question is also up there. How did you set clinicians up for success in these new roles? Some weekends were required, so longer work duty hours. Did anyone have any particular ways that they set clinicians up for success when they entered new roles? Could rotating weekends plus overtime?
Someone also added in how clinicians' job roles change was increased disinfecting on a regular basis.
Yeah, great. Great. Another one is providing recognition and clear communication from leadership. There's an intervention from the organizational level. So receiving recognition from hospital and government leaders was a motivational factor that supported COVID-19 clinicians' ability to continue delivering care. I think if you are in an administrative role or a leadership role within your clinic, take time to learn what other teams do and what other areas do. Don't wait until there's a crisis to learn about what they're doing. So it's genuine appreciation for the work that is being done. You should be transparent, bi-directional communication that empowers clinical teams and improves morale. And delivering current, reliable, and reassuring messaging improves transmission of critical information to clinical teams. So effective strategies include synthesizing information into a daily digest that links to a comprehensive resource page, and providing weekly virtual town halls to disseminate critical information. Another thing that's important for clinician well-being at the organizational level is to address and acknowledge moral injury. So the ethical, social, and professional obligation towards their profession are frequently reported as the core motivator for clinicians' decision to provide care while putting themselves at risk. And this commitment to serving others, even at the cost of their own well-being, makes clinicians a uniquely vulnerable population. The COVID-19 pandemic presented multiple potential sources of moral injury for clinicians, such as determining which patients would receive life support owing to inadequate resources, or bearing witness to and having to enforce policies that led to patients dying alone. Williamson and colleagues identified a set of strategies for addressing moral injury in frontline COVID-19 clinicians, and they recommended making clinicians aware of the possibility of moral injury and associated symptoms. So clinicians should be encouraged to seek informal support from colleagues, managers, chaplains, and have rapid access to professional help. However, it is known that those suffering from moral injury often fail to discuss it owing to shame and guilt. And as a result, leadership must proactively, consistently, and routinely monitor the psychological well-being of their teams. So investing in your clinical team and creating an environment of psychological safety is something that should be done consistently, just as a matter of routine, so we don't have to wait until times of public health crises. So how does your organization approach the topic of moral distress and injury? And if you don't have a formal approach or can't remember, maybe this will be a time for you to start creating an atmosphere where they do have an approach to moral distress and injury. And also there's sometimes people will include it on agendas. Thank you, Molly. So also at the peer and organizational level, we look at providing opportunities for peer and social support interventions. There have been several ways that people have provided peer and social support interventions, such as using battle buddies, where persons are paired with another person, and this was described by Albert and colleagues, and it involved implementing a battle buddy model, which was borrowed from the military, which paired individuals on the basis of clinical area and practice, career stage, and life circumstance. And each partner in the team engaged in daily conversation and looked out for the other's well-being. And if distress was observed, then they referred to having more formal mental health support, which was proactively deployed. And Walton and colleagues provide a comprehensive description of the physical, behavioral, emotional, and cognitive indicators of acute stress reactions. So it trains clinicians to be aware of these reactions in themselves and others, and may allow for better peer support and intervention. Mental health first aid is supplied by the National Council for Mental Wellbeing, and they offer several training programs. Other proposed solutions include routinely holding what is called Schwartz rounds, which is an interprofessional forum for healthcare professionals to discuss the emotional, social, and ethical challenges of work. And this often occurs during a shift change. So it's not very long, but it includes everybody, so they can feel more able to share their feelings. It is shown to show decreased isolation. Um, People feel more support and compassionate and feel like they have a chance to stabilize their emotions. Um, they also experience more compassion towards their patients. So, in order to save time, we're going to skip some of the Slido questions just so I can get through the slides and then save our questions for the end. So the provision of clinician mental health support is not currently standard practice in the United States. So there are self-report questionnaires and observations of frontline clinicians during the COVID-19 pandemic demonstrated that clinicians are unlikely to seek out psychological support resources despite the availability of these resources. And leadership can normalize mental health support by modeling self-care and help-seeking behaviors, ensuring that available mental health resources are well publicized, and developing a culture of caring with frequent check-ins with colleagues to assess psychological well-being and a protocol for professional referrals as needed. It's important to establish opportunities for clinicians to anonymously share concerns, which allow them to safely advocate for themselves and their patients. On a societal level, it is necessary to establish a new infrastructure that will sustain and supplement existing clinician support programs. Zhao and colleagues recommended an allocation of federal funding to care for clinicians who've been impacted by their COVID-19 service and establishing a national epidemiologic tracking program to track clinicians' well-being and the effect of wellness interventions. Developing multidisciplinary mental health teams at the regional and national level can allow clinicians greater access to needed resources. So there are two case studies we like to share. Bridget Gurley is currently the director of the nurse practitioner program at the University of Maryland, as well as a nurse practitioner at Anne Arundel Medical Group. She's a former NHSC scholar, and many of the students she teaches at the University of Maryland are currently working full-time as medical assistants while also in school and have to balance loyalty to their job and their own career. In her role as a nurse practitioner at Anne Arundel Medical Group, she used a tool for talking about vicarious trauma, as many colleagues were not prepared for witnessing pregnant women with severe cases of COVID and the decisions that needed to be made for their care. In their discussions, they start with what's been bad and what's been good to open the door for them and to share with peers. In our second case study, Kahina King was a dentist and also former National Health Service Corps scholar, is the dental services director at Good Samaritan Health Center in Atlanta, Georgia. Good Samaritan is a faith-based organization, and they held devotionals every morning as a way to create space for staff to share what they are going through. Those are held in partnership with a local women's auxiliary, which also held dinners for staff throughout the year. Good Samaritan Health Center took advantage of every opportunity to celebrate staff on birthdays, when they received a raise or a promotion, and they also celebrated baby showers, held parties for new hires, as well as departing staff or residents. And for birthdays, everyone receives a gift and a card signed by the entire staff. The AMA has provided a couple of examples for you to use if you are leading peer support sessions. So support and trust among colleagues within an organization is a key component of professional well-being in clinical medicine, and this support and trust is most crucial during times of significant stress, such as being involved in a medical error, the target of patient aggression, or being named in a lawsuit. In response to such adverse events, organizations must move away from a culture of shame and blame to one of support. And peer support is an essential component of this cultural change, and it represents an organizational shift. Another example is using Circle Up, which creates a regular time and place for problem solving and connection. It's used to promote better communication and improve the psychological well-being of care teams. Participants report greater interprofessional peer connectedness and less psychological distress, and they feel encouraged to speak up more throughout the day and with colleagues than they would normally not approach. Circle Up offers a proactive rather than reactive process of peer support that seems to work synergistically with clinical process improvements. So some things to think about before leading peer support sessions include how and when you would engage staff in these sessions, who would be the best people on your staff to lead these discussions, and how would you prepare for and respond to the responses you receive or issues that are raised. So we are quickly coming up on the hour, and I will leave a few minutes for any questions or comments that people may have. Thank you again for joining us.
Thank you so much, everyone, and thank you, Dr. Taylor-Desir, for that excellent presentation. If you have any questions coming through, please feel free to add those in the chat, or you can raise your hand by selecting the raise hand icon in the center right.
Molly has raised her hand. Molly, are you able to go ahead? Go ahead.
Yes, can you hear me okay?
Yes.
Okay. Yeah, thank you for that presentation, Dr. Taylor-Desir. I'm curious what challenges you run into in training leadership at healthcare agencies. What challenges do they experience in trying to provide peer support to their clinicians, provide opportunities for peer support?
Right. I think, you know, when I think a little bit about when I was the chief medical officer for an organization, sometimes you really have to just change the culture of meetings. And sometimes it may be really focused on negativity, and then really thinking about, let's talk positively, let's acknowledge good things that have happened. Let's acknowledge to each other positive things. And I think that creates an environment where people can then start to ask for help and lean on each other. I think the other thing is at other institutions where I've worked, it's really important to establish psychological safety from the time that you start working at a facility, because we established a helpline for our medical providers at the very, very beginning of the pandemic, and then people didn't want to use it, citing that they just didn't feel safe using those helplines. So it's really important to create that environment prior to a crisis.
Thank you.
Thanks again, everyone. We are coming to the end of our session, so I'm going to be opening up an evaluation poll. We'd really love for all of you to complete it to help us get a sense of what works well during these sessions, what will change, what do you want to see moving forward. So we'll give you a moment to fill that out. If you would like to gain a better understanding of any of the topics covered today, please see the references that are included at the end of this presentation, as well as those that were included in the chat. Thanks again to everyone for attending today's webinar, and for our tech support team who helped make everything possible. A quick reminder that the PowerPoint slides and related documents are available to you on the webinar registration page. It was linked in the chat. Our next webinar, Leading During a Public Health Crisis, Part 3, Measuring Burnout, is Wednesday, June 21st at 2 p.m. Eastern Standard Time. We encourage National Health Service Corps participants and leadership staff from NHSC approved sites to attend. Please make sure you're registered, and we hope to see you then. And thank you so much for all of you as you are finishing up the evaluation poll. We'll leave that open for just another moment. One final thank you to Dr. Taylor-Desir for a fantastic presentation. And we look forward to seeing you all next week. Thanks, everyone. Have a great afternoon.
Thank you.